So nice to meet you, everybody here in person, and just to greet everybody who is online present and listening to this lecture. And hopefully, if they will be published later on the website, everybody can see them later on. It's my pleasure to be here as a lecturer. It's maybe for the first time a topic which is very interesting, that robotics is still not present in Macedonia. So I don't have any personal experience, but nevertheless, because previous lectures I have prepared for the GYNOCARE were full of data, of studies, analysis, meta-analysis, systematic reviews, and so on. I decided this time, because I have seen that in the program that Lachazar, Iksan, Tim later on will speak, and probably we will overlap in some of the parts of the lectures. And probably they are working and they will share with us their personal experience. This is more like a, let's say, intro of this session. And I will try to be as short as possible, as interesting as possible, just to remind ourselves what are actually the main differences. Even before start, I can say that during the coffee break, we were talking and discussing in this patient advocacy session that actually the human touch, the touch when you operate, is so important, and the touch between patients and the doctors is so important, and the conversation between the doctor and the patient is so important, that actually, unfortunately, due to this digital technology advance times and periods, we're actually transferring to another type of surgery as well. As we all know, laparoscopy was a boom when it showed up, and we will see what are the benefits. But still, in a certain way, we don't have the personal contact with the patient. We just put the holes inside. I'm doing laparoscopy for almost 22 years. We put the holes inside, then you have to find the real position. You position yourself, and you're doing something inside of the abdomen, on the pelvis in the women, just by using some kind of sticks. It's just like Chinese cuisine. But still it's very tasty because it's very good for our patients, it's very beneficial. They can live the same day or the next day instead of staying in hospital for so many days. So we just want to do what's the best for them. And obviously laparoscopy is part of it. What is robotic actually? It's actually robot-assisted surgery. We're talking about robotics for me, and we will touch that point as well. It's that you have somebody doing the job for you. When we say robot, now we have cleaning robots in our rooms, in our apartments. We have Wi-Fi communication with our appliances at home. They can be controlled by the machine, by the artificial intelligence. In this case, actually, it's a robot, it's a helper, which actually assists us humans, us as a doctors as well, to have a better position and better option to treat our patients. That means if we do something with laparoscopy and we struggle with 2D technology, with some, let's say, losing some of the movements and of the gentleness in our touch, and some of the other let's say, positions when you operate in open surgery, with robotics, that's another way to put those sticks as close as possible to this open surgery. Usually, robotics is, of course, when we talk robotic, we think about minimally invasive surgery, even though it can be in some open surgeries as well used. So we all know what are the general. So we are reducing the risk of injury with laparoscopy. We are reducing the pain during recovery. We have shorter hospital stay. We have reduced usage of anesthesia, reduced wound infections and complications, less blood loss and faster recovery time, minimized pain and discomfort. We help patients to return to normal activities soon, and we have better cosmetic results. So we all know what are the, let's say, advantages of laparoscopic surgery over open surgery. And still, it has been documented in many studies And in many circumstances, that's the best option we can propose to our patients. Again, we have actually some kind of risks. We have long learning curve because it's a demanding procedure, especially if we are talking about some kind of complex surgeries which involve like deep endometriosis or some gynecological oncology or some previously patients who have been previously operated and so on, where there are a lot of adhesions. Here you can see that there are some risks also which are associated with laparoscopy, nor more nor less with others which are connected with abdominal hysterectomy, for example. So laparoscopic hysterectomy and abdominal hysterectomy, they have the same advantages like for other included operations done by laparoscopy. But what about gynecological oncology? We can hear something more about that later on versus robotics. But laparoscopy actually was a method which we try to use as much as possible doing gynecological oncology. And regarding the importance of the overall survival and progression of the free survival in cancerous patients, we should consider this type of surgery very wisely, not to rush to operate any of the patients with minimally invasive surgery just for our own benefit or just for some study results. And usually in most of the cases, actually the laparoscopy is a better option for our patients if they are with early diagnosis of the gynecological oncology. What are the benefits of laparoscopy? So comparing with the open surgery, you have the image magnification, so you can easily visualize metastatic or recurrent disease in the deep pelvis. So magnification of the laparoscopy is a extremely beneficial point in any surgery, but especially in this part. And then you can improve your dissection. You can have fewer injuries in challenging areas such as retroperitoneum. So that's very obvious and very known. We know that we have decreased bleeding from small vessels due to pressure from pneumoperitoneum, shorter hospital stays, and faster recovery. We have less postoperative complications such as ileus, small bowel obstruction, wound infection and separation, and thromboembolic events. We can apply postoperative chemotherapy or radiation earlier than when we are doing open surgery. And there is no need for incisional hernia repair later on if we do a massive open surgery incision. However, about the long-term survival and cancer-free period and overall survival, there have been some studies. Not all of them are actually so up-to-date. Some of them, now we have here the Da Vinci, the 4th generation robot in the lobby, but some of the studies which are used actually in these studies are discussing the previous robots which had less options and more modification for some surgeries that they have to be done. But it's also important that some of the studies actually are comparing open surgery versus laparoscopic like conventional and robotic altogether. So in the complex procedures, actually robotics is always better, and sometimes it's even proposed for some operations where we cannot do conventional laparoscopy. So what are the benefits? Superior dexterity, intuitive movements, 3D vision, improved ergonomics, autonomy of camera control, shorter learning curve for doing the robotics, not for doing the operations. Robotic movements are filtered for tremor, and 3D camera is secured and controlled by the surgeon, allowing for more exact dissection by enabling depth appreciation. So it's actually proven that, especially for the obese patients, but also for non-obese, for normal patients, that actually it's very important and it's better to operate in robotic surgery. And also the movement outside this tremor stuff, but also the movement of the hand is actually in the same, it replicates the movement of the surgeon's hand, and it's not counterintuitive. The disadvantages of the robotics is like the actually partially maybe the one we have at the laparoscopy. is the lack of haptic feedback. You cannot touch, you cannot feel the structures and so on. The surgeon is positioned away from the patients. It has higher cost. It's questionable. We can touch that question as well. And it needs a structured training program. Structured training program both for robotics and both for the gynecological oncology. Actually, if you do a lot of robotic surgeries with the same robot, sometimes actually you can save money because you have shortened operating time, you can have a lot of operations, you can have patients who will stay less at the hospital, and actually you will have less cost and implication associated with the conversion to laparotomy in some of the situations. And in some of the studies, which are actually not so new, but still you can see that at the rate of maybe 300 to 400 interventions per year, the cost of actually robotic surgery, robotic assisted laparoscopic surgery is more or less like the laparoscopic and cheaper than the open surgery. So we have a lot of things to talk about what are the benefits, and we have mentioned all of this before, and it's very important to offer this to our patients. And some of the main associations in the world, like American College of Obstetricians and Gynecologists, Society of Gynaecological Surgeons, but also Royal College of Obstetrics and Gynecology has the latest in July 2022. They actually suggest these recommendations for us, for the doctors, but also for the patients. That it can be performed safely in centers with experienced surgeons and has peri-operative outcomes equivalent to laparoscopy and improved outcomes compared with laparotomy. The cases should be selected based on the likelihood of the improved outcomes compared with other surgical approaches. So not just to rush them to robotic surgery. It's an alternative surgical tool for MIS, and we need more studies to see which groups and which subgroups of the patients are actually the most beneficial one for this robot-assisted approach. As with any procedure, our patient should be informed, and we should obtain informed consent from our patients. So what is the indication, what are potential risks and benefits associated with the robot-assisted technique. If we compare the complications, here are some also unusual complications which we don't see in conventional laparoscopy, like there was some pressure and some nerve pulses and paresis and paralysis from the arms of the robot. We have some eye damage of the proximity of the camera involved. We had also, in a certain way, depends. Sometimes people say, oh, robotic is safe, but not always. Conventional laparoscopists actually can be very excellent and comparable with the results with the robotic surgery. In most of the studies, probably, and Lachazar will mention something about it, there was no comparison with the knowledge and experience of the robotic surgeon and of the laparoscopic surgeon, which is also very important. It's maybe easier to learn robotic surgery, but that doesn't qualify you as a better surgeon than one who is doing the conventional laparoscopy. So we should always be honest with our patients and tell them what is the best options for them. This part will probably be covered in the next presentation, but we have to mention that actually we have surgical procedures which are also like exenterative procedures and some others which are only designed for robotics and not applied for the laparoscopic. In endometrial cancer, we have also in those complex cases, because laparoscopy involves anesthesia and specific positioning of the woman, actually in some kind of comorbidities, like obesity or pulmonary problems, actually robotic can deliver better results. In endometrial cancer, actually doing hysterectomies and doing lymphadenectomies in certain cases have been actually proved in the studies that can improve survival and reduce the risk of severe complications. So in those cases, we can, in centers where they have really experienced surgeons, propose, and probably the future goes into that direction, that laparoscopy, robotic laparoscopy probably in the future will be the golden standard to do the procedure. And if you compare some of the results, there are not so many differences. The main step forward in gynecological oncology and in gynecology is open towards laparoscopy. Laparoscopy and robotic-assisted laparoscopy surgery are not so different in their results. They are maybe a little bit longer doing robotics, a little bit less blood volume, but if you see the results here, the difference is 50 milliliters. So it's almost no difference. Not different for the patients, actually. But still, the period of, for example, the mean length of stay, it's also here. In laparoscopy, robotic is 1.26 days, and in laparoscopic is 1.78. It's a difference of 4 or 5 hours. So it's totally unimportant. What is important is to do the right operation for the right diagnosis. And in cervical cancer, actually, in radical operations, in early stage cervical cancer, actually the robotics was also proposed and laparoscopic was also proposed, but actually the LEC study, which was done multicentrically in 33 centers, but most of them actually, probably there can be some bias. 84% were done laparoscopically, only 16% were done actually robotic. And comparing with open surgery and with difference in the knowledge of the surgeon itself, it showed actually, and some parts of the study were actually stopped because after 3 years period of time, there was starting difference of 4% recurrence rate and overall survival rate, and it enlarged after 4.5, 5 years to almost 10%. So we have to be honest to our patients, and that's how actually the UK National Cancer Registration Analysis Services, European Society of Gynaecological Oncology, American College of Gynaecological Oncology, they all issue actually safety recommendations for the start. They recommended open surgery to be the gold standard, but not to automatically throw away all the possibilities of the robotic surgery and of a proper randomized control studies. So the recommendations is actually that prospectively all future experienced surgeons done in specialized centers should be encouraged to do robotic laparoscopic assisted surgery and just see what the results at the end would be. These are some of the comparison between robotic and laparoscopic. What is also important, so we said endometrial probably is the situation in the future. Robotic will be some kind of standard. For cervical, we still have to search because the results are contradictory. And in ovarian cancer actually can be very helpful, and these surgeries actually are probably in well-chosen patients, good for staging of the ovarian cancer, but also for the reoperations and for doing all these necessary surgical procedures. So, of course, it has all the benefits from the operating period, but also it's a question of chemotherapy, which can be started sooner than in patient with an open surgery. And just 2 more slides. One of the extremely beneficial possibilities of the actually robotic surgery is telesurgery, and it has been advancing more and more, and probably it should be and it can be done and teach and used in peaceful times, but especially in periods of disasters. Maybe it's not so much for gynecological oncology, but for all kind of operations. If you have a proper telecommunication, proper connection, actually it can be very helpful if somebody who is experienced can help you using the robot actually you are using at your hospital. And it's very educational as well. But again, in the future, it's the big question. We are more and more using robotic and high technology to treat our patients, but maybe in the future there will be hospitals where we will go with our diagnosis and maybe the robots will operate on us as we do on animals. Thank you very much.